All right, well, welcome everyone to this February session of the Virtual Learning Collaborative, using a health equity approach to improve data collection and the use of demographic data, made possible in partnership with the CDC Division of Viral Hepatitis. Good afternoon, my name is Zakia Grubbs, she, her pronouns, and I'm a manager on the hepatitis team. Joining us today are Kelsa Lowe and Kaylin Mitchell of the Wisconsin Department of Health Services, and Kevin Heslin from the CDC Division of Viral Hepatitis. The format for today's session is as follows. We will begin with a presentation by Kelsa, followed by a Q&A and discussion facilitated by Kevin. Feel free to use the chat to introduce yourselves and your jurisdictions, and if you all have any questions. In about 2 weeks, on February 27th, we will continue this conversation in the form of office hours that we will facilitate with objectives to really get into the nitty-gritty of some of the things we're learning today, and also to have more candid conversations. So thank you all for joining us, and I am going to turn it, I forgot to advance my slides. Yeah, so that's what I just said, and I'm going to turn it over to Kelsa.
Great, thanks, Zakia, and hello, everyone. Give me just a moment here to share my screen. The NASA team invited Wisconsin over today to present on data collection, improving data collection, and utilizing demographic health equity. And the processes that we've implemented. My name is Kelsa Lowe. I'm the Hep C Epi at the Wisconsin Department of Health Services. I've been at the department for about 8 months now, so I don't have a ton of historical knowledge on past procedures, but I'm hoping to share with you all today our current processes for improving data collection among demographic data and what our plans are to move forward. I'm also joined with my colleague, Kaylin Mitchell, who's also on the line, if you'd like to introduce yourself.
Sure, thank you. My name's Kaylin Mitchell, pronouns are she, her. I was the former Hep C surveillance specialist for over 5 years in our Wisconsin Hep C program, and now for the past over a year, I've been the hepatitis prevention coordinator. So just here to add some insight and support today.
Great, thank you. Alrighty, so throughout this presentation, I'm hoping to do a couple things. First off, I'll kind of begin by creating a scene into our little Wisconsin world, where I'm hoping to briefly discuss our surveillance system, some laboratory reporting, our collaborations, and organizational structure. By the end of this presentation, I'm hoping you'll come away with some ideas to enhance your own surveillance data. I'm also hoping this can kind of be a round table to share ideas and offer suggestions across jurisdictions. So this is also going to be a huge learning opportunity and experience for me, as it is for many of you, I hope. But before we jump into it, I have a couple polling questions I'm hoping folks could answer. And I think Zakia might throw those into this. All right.
Can you all see them?
Yes.
Yes. Mm-hmm.
Okay, thank you. There's 3 questions. Someone read them aloud.
Just going to give folks a few more seconds for this process.
Yep, and if in case folks are on the line and they can't hear the questions, the first one is, where are you at in developing a surveillance system? The second one is, do you have one surveillance system or multiple? And the third question is, how long have you worked in hepatitis C prevention or surveillance? And I think we're at like 60%. Is that good?
Sure. Yeah. Let's go ahead and stop the poll. Thank you so much. All right, let's share those results. Cool. So the first question here, we have about 18% of folks in early stage development of their surveillance system, about half in advanced, and 32% middle stage. I think that's a really solid range of folks. Um, Apologies to all the advanced surveillance folks in the room. This is really going to, I hope, be really helpful in early and middle stage development. But I'm always that person who learns something on every call. So I hope that we can all kind of learn something together. Second question here, do you have one system or multiple? Looks like 44%, one that encompasses all diseases. Few folks have 4 or more, and some don't have a surveillance system in existence. All righty. And then the last question here, how long have you worked in Hep C prevention or surveillance? We have a little bit of a range here as well, about 39% less than a year, and then a little scattered from there. Awesome. Thank you so much, everyone, for participating in that. It's just really good to get an idea of who's in the room and kind of how this presentation will hopefully help some of you. All right. So to kind of jump into it, I wanted to start off by spending a couple minutes setting the stage, but I wanted to preface by saying that our work isn't really done in silos, at least in Wisconsin, and we have a really robust relationship with our surveillance system folks and other programs and collaborators, and that's really a huge mechanism for us to be able to improve our demographic data. So just a little background for you here. Surveillance of chronic Hep C infection began in Wisconsin in the year 2000 and was moved to an electronic system in the year 2007. We refer to our surveillance system as WEDSS, which is the Wisconsin Electronic Disease Surveillance System. Hepatitis C is a designated Category 2 disease under state statute and must be reported within 72 hours upon recognition of a case or a suspected case. WEDSS, our surveillance system, is the only surveillance system utilized by all communicable diseases in Wisconsin, including all nationally notifiable diseases and all other communicable diseases with reporting requirements. So this is really kind of what I wanted to preface here is that this has implications for some of our data matching down the road, which I'll begin to discuss in just a few slides here, which might look a little bit different for those of you who have 2 or more surveillance systems. So cases are primarily reported electronically to WEDSS, and this is done through 2 main mechanisms. The first is web reports, which comes directly from healthcare providers, and the other is electronic laboratory reports. So surveillance of Hep C is meant to capture 3 key aspects of a case that has Hep C, which is clinical information, laboratory test results, and risk or epidemiologic information. Additionally, there are multiple organizational entities involved in the operation of WEDSS. It's a cloud-based system that's hosted by a third-party vendor known as SunQuest. SunQuest is also adequately staffed and available for technical support at the request of our organization or others when it's useful and needed. Alrighty. And so without the robust capabilities of our surveillance system, data collection and completion would look very different. The relationship that we've built with the WEDSS team has been really crucial to the implementation of any project or data collection improvement process, which again, I'll get into in just a moment here. But this diagram is really meant to show where our program resides in relationship to our surveillance system team of experts. So while we're all under the Division of Public Health, we do operate within our own offices and function more like our own bureaus. So WEDSS has 4 key system administrators responsible for applying updates and working with program staff to ensure that WEDSS is meeting the needs of disease-specific reporting. These individuals also help in the implementation of automation. So this is kind of an example of what one of the automation or automated imports looks like, or logic rules looks like within our surveillance system. So automation analyzes an incoming record and lab results being imported and specifically looks at whether there's an RNA result, what the result is, if there's an antibody or what the result of that test was, if there's a genotype or a web report, what have you. It looks at everything, and then it'll match the results of those incoming records to our surveillance system to determine whether the person exists in the system already, whether they have an existing disease investigation status within their existing record. And then it kind of places them as needed. So if a negative case were to, or a negative antibody comes in, then we know to designate them as not a case. And this really helps to improve our workload. It helps to reduce our workload so we don't have to manually review every case. This also really helps with local health departments so they don't have to review every case or, go down and close all not a cases. So this has been really crucial for the development of our program and our workload. We actually, just a fun little fact that I'll throw out there, we actually met with our Hep B team this morning and worked on some automations for our Hep B team. So we're also always improving our automation techniques and across programs. So this is something that's been new to us over the past few years since COVID, and something that we constantly try to utilize to the best of our abilities, and highly recommend that other programs and other jurisdictions use this if it's accessible and available to you. So in addition to our WEDSS support team, or in addition to our 4 system administrators, we also have 2 WEDSS trainers who provide general WEDSS training to local and tribal health departments, in addition to WEDSS operators, which also includes onboarding health systems into the surveillance system so that clinical environments can easily learn how to report cases to us electronically. DHS also employs a team of informaticists who oversee data system connections and reporting to CDC, as well as system maintenance. So additional staff are positioned in the Wisconsin State Lab of Hygiene, which helps to coordinate electronic lab results. And also the Wisconsin State Lab of Hygiene really helps to communicate with laboratory partners across the state to increase quality of reporting and provide technical assistance. So without our relationship with our state lab, we wouldn't be able to really implement as high level as we currently do. So we really rely on a lot of our collaborators and partnerships. Alrighty, so next up, we're gonna dive a little deeper into the inner workings of our program and where we're currently at in data collection and data equity. So before I dive too heavily into that, I did want to preface that Wisconsin Medicaid Hep C treatment has no sobriety restrictions, no provider restrictions, no disease severity restrictions, no prior authorizations are needed, and retreatment is considered. So this really helps folks in Wisconsin to reduce barriers in place for the purpose of screening and treatment services. It allots itself to buy-in, and once Medicaid reduced treatment restrictions, it really opened the door for specifically DOC and other clinical environments to expand upon universal screening recommendations, as these are ultimately tied to treatment restrictions. So this has really improved and had huge implications to health equity. If people aren't getting screened, they never, they won't know if they need treatment. So this may prevent many jurisdictions from developing universal screening practices. So I would say that this is ultimately a very high priority item. Okay, and this organizational chart here looks a little busy, but I wanted to specifically highlight our harm reduction section under the Bureau of Communicable Diseases. This section encompasses programs across HIV prevention, HIV care, HIV surveillance, along with STIs, hepatitis C, and harm reduction. In effect, we collaborate with these programs very closely and really try to create more of a syndemic network across these conditions. However, our Hep C program is specifically listed under the harm reduction unit, as you'll see in the green box here. So you can probably tell at this point that I really love charts, but I promise this is the last one for now. One of the most gratifying ways that we represent equity and health in our program is the way that we've designed our program. So we are currently working on onboarding a harm reduction response team, which we've called HRRT. And this response team will host 2 mobile vans that will it will host outreach specialists, behavioral health specialists, and an RN. We're currently working on protocol development, but these vans should hit the streets this year. And at the end of the day, screening vulnerable populations and meeting people where they are and truly utilizing that harm reduction approach is our utmost priority for this team. So we really use that concept to build upon all of our elimination, prevention, and surveillance goals. So what I wanted to really address here is that we work as a team and collaborate very regularly. Our viral hepatitis prevention coordinator, Kaylin, will oftentimes facilitate partnerships and build relationships with community-based organizations, with health centers, tribal centers, et cetera. And she does this across the state of Wisconsin and brings folks together. Our surveillance and elimination teams will work together to train local health departments. We present to our communities and bring data to our communities. We bring responses back and improve our surveillance system. And we really try to allow for a feedback mechanism to go bidirectionally. So I wanted to plug this into our conversation to highlight really the importance of working with our communities. In addition, we've been very creative with our funding mechanisms to allow for the establishment of our program. And so you can see kind of in the top right corner here, some of the funding mechanisms that we have in place to allow for a mobile harm reduction team, our elimination planning, and our surveillance folks to kind of all coalesce into one program. I just wanted to throw this to Kaylin if she had any other thoughts on this slide.
Thank you. Yeah, I just wanted to mention that for anyone that is new to hepatitis work or potentially doesn't have programs that are built out enough, that's okay, because our program used to be a program of one who our current harm reduction unit supervisor, Sheila Guilfoyle, was the hepatitis prevention coordinator for quite some time, and then slowly built it up and added an epidemiologist over a decade ago. And then I was the first Hep C surveillance specialist. That position was created over 6 years ago. And then you see from there in recent years with the influx of additional public health funding and using different funding mechanisms like Kelsa has in the corner, then we were able to even further expand and add Hep C dedicated DIS, drug user health coordinator, and pursue the HRRT harm reduction response team. And really, this has really expanded over the last 3 years since the pandemic began. So if you're not there yet, that's okay, because our programs had lots of years to expand and develop.
Great. Alrighty, so next up, I just wanted to really discuss some data quality within our department specifically. Ultimately, measuring race and ethnicity has really important implications for public health and is integral to understand and address and begin to address healthcare access disparities. So in this section, I'll just dive a little bit deeper into the inner workings of our program and where we're at in our current data collection and data equity process. So I just wanted to kind of provide a little bit of a picture of where we're at in our case reports, and specifically the percentage of case reports with complete information from demographic data that we collect. So as you can see on the left-hand side of the screen, some of our chronic hepatitis C case reports, we had 1,515 chronic cases reporting reported during year 2 of the grant process, in which we had 99 to 100% completeness. And then on our acute side, on the right-hand side here, all of our acute cases, we had 84 acutes that were reported in year 2, and it stems from 92% in age and then 100% through the other case reports with complete information. So just to provide a little bit of background there. This has not been done overnight. This has been a long time pivot and progress, workflow development, and it's taken many, many years. Progression naturally involves many pivots, so I would just encourage pivoting where it makes sense. I've kind of highlighted a couple of different components on the slide here where we've continued pivoting. So over the course of the past few years, we've made many pivots towards improving the products we provide to the community. Our goal is really to provide digestible information and Hep C information to the public. We also continue to assess terminology and the terminology that we use in our reports and how we, talk with our communities and bring information to our communities. This has really huge implications for equity, and language really does matter. So some examples of some terminology changes we've made. We have started to use terms like Native and Indigenous populations in place of American Indian or like terminology. In addition, instead of using the term risk factors, we are moving towards the term exposure. I think one other example is pregnant persons in place of women, which can be a little bit of a data limitation there. So for example, one of the specific populations we look heavily, or we kind of examine a little bit more heavily, is women of childbearing age. So that's a little bit of a data limitation there. But overall, presenting which terminology you use is incredibly important. In addition to those two components, utilizing some auto importing rules, as we've discussed above, has been really influential in reducing our workload and improving case classification procedures. And electronic reporting has been incredibly important, and as well as implementing case definition changes rather quickly. We're already kind of a year behind every year, given case closeout. So kind of implementing case definition changes rather quickly allows us to kind of be more towards the forefront as possible. All right, and I am going to pass it over to Kaylin to discuss this slide.
Thank you. So as Kelsa already mentioned and alluded to, we are very big in our statewide partnerships, and especially earlier in the program when we had far less staff capacity and resources, and historically hepatitis just has been underfunded compared to other infectious diseases. So we have a robust relationship with the Wisconsin State Lab of Hygiene. They do a lot of testing statewide, and they also do Department of Corrections, prison testing, and they also help with our outreach sites that we provide rapid Hep C testing to, and then they can do antibody and confirmatory testing, so doing the blood draw samples. So they're a major, major partner for us, and we have constant communication with them. In addition, our local and tribal health departments are a huge partner. One of the main partners in customer service, technical assistance we provide at the state is to local and tribal health departments, because like I mentioned in the chat, we are a home rule state. So they are the authority in their county. They have control over their cases. It all goes directly to them first. And then if they need any assistance with questions, follow-up, case classification, anything that they need, we assist them. Our Wisconsin Electronic Disease Surveillance System, WEDSS, those staff assist them. State Lab of Hygiene also assists the local and tribal health departments. And two, if they need to submit lab samples or something, the state lab can help the local and tribal health department. So lots of crossover. Like we mentioned, Department of Corrections is a big partner for us. Our boss has implemented a quarterly meeting with DOC for all communicable disease for the past 20 years. And again, that strong partnership has led to screening of Hep C universally, moving towards treatment, and they have a 9 to 11% of all of our Hep C cases for the state are in the prison system. Local healthcare systems are another big part of our work, and that's one thing that when I joined the program, I started providing a lot of trainings for healthcare providers, their supporting staff, bringing awareness about Hep C testing and treatment. In addition, we've had a robust syringe service program network in our state for, again, 20 to 30 years. We've had that. So that's really led to our low rates in HIV and keeping that low. And then they're a great partner in trying to provide additional Hep C testing that those people who are served by those programs might not be able to access anywhere else because they you most likely not have a primary healthcare provider. So then they can get tested at those programs. Again, when we do any support of local health departments, that sometimes involves us reaching out to healthcare providers, infection preventionists, our surveillance specialist, Caroline Moore, does this a lot, following up on cases, making sure they're classified correctly. And then our new position, Hep C DIS, Emily Hacker, will also be helping with that, in addition to lots of talking back and forth with health department staff. There's always continued conversations with plasma and blood donation centers. We're looking to do more intensive trainings with these as far as reporting guidelines in 2023. We have a HIV prevention grant that most states receive, and as part of that, there's a set amount of money provided to all 11 of our federally recognized tribes in Wisconsin. And what comes from that is there's 11 HIV tribal coordinators. So over the years of me being in the program, I've transitioned into leading those quarterly meetings and maintaining their prevention grant and looking at their objectives and bringing trainers in for them. And again, our whole section provides TA, we provide surveillance updates, and just any connection they're looking for as far as testing, treatment, healthcare provider trainings. GLITEC, the Great Lakes Intertribal Epidemiology Center, is another good partner that we've had, and they also do great work with the local and tribal health departments and also come to the tribal coordinators meetings. They get separate funding, and that has been really great. I can always speak more to that later if there's questions, but there's been some testing available for free through that. So they're just another good partner. I believe the tribes also can order like condoms and other prevention things for free through them. So we connect with them often. There's also that EPI connection where we're assessing our data and looking for ways to improve it. University of Wisconsin-Madison is a huge partner. Through state government, sometimes there's a cap on the amount of state positions, and we're able to, if there's grant funding that's coming in, to figure out contracting positions through UW-Madison. So that's what my position used to be as a surveillance specialist. So there's lots of partnerships with UW-Madison, but one way that they've always helped DHS is just support in increasing staffing capacity for public health. There is a HIV statewide action planning group. Again, that's kind of mandated with HIV prevention grants across the nation. So ours is just called SAPG. And that's another platform where we can go and provide updates on Hep C, gather feedback, hear questions, concerns, ideas from community members who are either living with HIV or working in the field or both, or maybe receiving HIV prevention grant funding. So that's just a small taste of different venues, different partnerships that we have. And then something new that we just did our first community webinar is we're starting up our Hep C elimination community webinars. And then we're also going to expand from that and have some smaller work groups to work towards a statewide elimination plan. So definitely a lot of collaboration across systems and programs. And I'll turn it back over to Kelsa.
Alrighty, so just to kind of recap our conversation thus far, some key elements in vamping data collection and data quality improvements. So some items that we've discussed already, building a good relationship with surveillance and IT teams, and really spotlighting building that robust surveillance system. This, for example, has really helped us to get providers set up in WEDSS, our surveillance system. Number two here, building laboratory coordination to ensure quality of reporting and case classification data elements. So a couple of things that we are currently doing and some items that we're looking to do this year. This year we have dispersed a lab survey to the State Lab of Hygiene, which will ultimately provide that survey to all labs in the state of Wisconsin. This will help us to assess laboratory reporting to us, negative reporting, and potentially the inclusion of other data elements that are more clinical. Additionally, we have begun implementation of ECR this year. And something that we currently do and look forward to continue to complete is the automation of race, ethnicity, and other demographic data, as well as tracking. So this is kind of another laboratory component. We do have negative RNAs are reportable in the state of Wisconsin. So just continuing to track and monitor the lab systems. And when they fall off, when they come back up, if there's a new lab, if there's been a merger, et cetera. Number three here, really collaborating internally is crucial, and data equity and language matters. And then number five, community feedback and external collaborations. These are all highly foundational and absolutely an infrastructure when you're building upon either the development of a surveillance system or improving demographic data collection. These are really foundational components. Alrighty, so the next system we're going into is kind of discussing the development of health equity in data and developing consistent and useful approaches to demographic classifications. So I wanted to start off by highlighting this resource that was published in December by the Network for Public Health Law. It discusses some barriers that public health departments are facing in collecting demographic data and really tries to provide some solutions. The priority item, as designated by the title, is to disaggregate racial and ethnic data and discuss disaggregation as within these groups, which is essentially the process of splitting large general categories into more specific groups. So an example of this would be to disaggregate Asian to Vietnamese, Chinese, Hmong groups, et cetera. So a paper published by Public Health Reports in 2021 looked into disparities among Asian American patients at New York City's public hospital system. One key finding found that South Asian and Chinese American people experience adverse COVID-19 outcomes and high rates that are similar to rates observed among Black and Hispanic people, and underscores the importance of disaggregating Asian ethnic groups in data collection and reporting processes to better inform public health. So something that our team is looking to improve upon, and something that this resource here highlights is that disaggregation piece. So while this resource really dives into disaggregation to further represent healthcare and health equity concerns, there are some other foundational pieces in regards to gathering demographic data that this resource provides. So while I'm not offering any legal advice or advocating for any penalties, I just wanted to highlight that HIPAA allows for public health data collection. So there's a data pathway if there isn't a data pathway that is being utilized, that you want to be utilized, states can determine whether to use the existing legal authority to collect race and ethnicity data that otherwise may not be currently collected. States can additionally explore whether to explicitly mandate reporting of demographic data or to adopt a penalty structure in place for failure of compliance. And one thing that this resource pointed out is that, while folks and jurisdictions may not use or adopt penalty structures for non-reporting, some of the primary barriers in place for collecting this data includes patient hesitancy, provider non-reporting, and technological issues. So I guess determining, where your jurisdiction's at and what barriers are in place for your jurisdiction, and then working to, again, bridge some of those barriers and connect with some of those partners, whether it's a tech concern or a provider concern, to start to bridge some of those gaps is something initially to start considering. Okay, so this slide's a little busy and I'm going to explain it a little bit more. So in a standard and a typical data flow procedure, patients will seek out healthcare services and entities report data to public health agencies. This is true for Wisconsin as it is most other jurisdictions. However, in Wisconsin, we have one other data flow into this step, which is our usage of rapid test results. So we provide rapid tests to our external partners at Vivint Health, which has locations across the entire state. We also provide rapid tests to a couple of other sites, including sites known as UMO 16th Street and 2 local health departments that also have syringe service programs. So these rapid test results are then reported back to us, and we import these results into our surveillance system for only state level folks to view. So these Hep C rapid tests provided by our department has 3 primary functions. First off, it improves acute data quality by by visualizing the result in the system. If a new Hep C test belongs to a person who previously had a negative rapid, we're able to decipher then if that test was in a 12-month time frame, whether or not that's an acute case. Second, testing is provided to underserved populations who might have unequal access to healthcare services due to various inequities. And third, it helps to improve our demographic data, which I'll get into in just a moment. So in 2022, we received 2,031 total rapid tests from Vivint Health alone. Of these tests reported to us, only 12 had unknown age ranges, 62 had unknown genders, 47 unknown race, and 47 unknown ethnicity. Of the over 2,000 tests that were reported to WEDSS, 107 or 5.3% of these persons were newly added to WEDSS. So 5% of these people newly added to WEDSS really indicates that they were not yet in our surveillance system with any results of any reported communicable disease. In addition, approximately 93% of people had one other disease incident indicated in WEDSS. So overall testing in this population is very low across all communicable diseases. And then you can see from the far right-hand side of this slide, 14% of this population had a reactive test result. So overall, we leverage our existing partnerships with syringe service programs who have a rapport with underserved members in our community, along with members who have possibly more exposures to hepatitis C. And because of this developed rapport, the information we collect is substantially helpful in not only development of our demographic data, but also our case classification. So going more into our case classification and demographic data. So again, this information is from Vivint Health in 2022. With the data that was collected out in the field, we were able to improve our demographic data in our surveillance system across all person IDs. So you can see here the number of additions we've made across ethnicity, race, and gender. A couple of ones that I wanted to highlight here is there were 114 additions to Hispanic Latino, 18 additions to Native populations, 88 additions to Black or African American, and then 3 additions to transgender female to male, 1 addition to transgender male to female. So these adjustments in our person level demographic data may not otherwise have been completed if it weren't for any rapid tests that were provided to community members, as this is really an underserved population. Again, most of these folks don't have many other disease incidents or testings or screenings provided back to us that are reported. So being underserved and having kind of unequal access to healthcare services and a lack of healthcare services kind of in place here, this is one methodology or one mechanism for us to be able to improve our demographic data among a highly underserved population. So after all of this is said and done, 32% of people were updated with ethnicity records, 26% with race records, and 21.5% had updated gender records. Okay, and I'm going to take a little bit of a tangent here. So this is less about demographic data, but I wanted to put a little plug in here on exposures. Number of exposure categories we ask for in our prevention sites. We ask for ever injecting drugs, ever shared snorting equipment, ever shared equipment or smoking equipment, injection drug use in the past 6 months, and sharing equipment in the past 6 months. You can see here the trend illustrated among those with non-reactive versus reactive results within exposure categories. Specifically, people with more exposures to injecting drugs or sharing equipment have an increased chance of being exposed to Hep C. So we have more Hep C reactives among people with these increased exposures. So I wanted to also illustrate here that all of our rapid data that gets imported into our surveillance system that's only visible to state employees will then carry over this information to other Hep C disease incidents that are created if folks go through that standard traditional reporting process. So if folks, come in, get their blood drawn, and then we have a confirmatory test that gets reported to us, all this information will then carry over. So we have improved acute cases, we have improved risk factor information in our surveillance system, and we can continue to track all of these exposures over time to see where our acute cases are within all of these different exposures. Okay, so to improve equity, we must first improve the data that we have available to us. So we've kind of gone through this workflow a few times, and you can see here how much we've progressed over the past 10 years specifically. So on the left-hand column, you'll see our cleaning codes from 2013. On the right-hand column, our cleaning codes now in 2023. And actually, this is not an exhaustive list of all of our cleaning codes, but you'll see in 2013, we had primary cleaning codes for duplicates, missing race or ethnicity, those who are out of state, and then checking the resolution status. Well, we still have all of those cleaning codes in 2023. We also look for Hep C labs in non-Hep C incidents. We look for possible acute cases, perinatal cases. We look for folks who may have had test conversions. We check for labs and confirm resolution status, really a number of things. So I just wanted to add here that if anyone is struggling with cleaning some data, you can always reach out to me, and I'm happy to provide any SAS code as well if that's helpful for jurisdictions. But I highly recommend, given the amount of labs that come in for Hep C, that cleaning data is extremely important. So please reach out if anyone needs any assistance there. Okay, on a quarterly basis, we also run this code, which is really tiny in this first box here. So this code is our unknown race, ethnicity, and sex code. So this code pulls out all missing or unknown race, ethnicity, or sex categories found within each individual hepatitis C disease incident in our surveillance system. Then we're able to conduct a matching process. So you'll see in the second diagram here, we match all of the unknown cases against other disease incidents, and this is provided to our surveillance system, and they conduct the matching. Because we have one surveillance system that that's the primary provider for all of the communicable diseases across our department, it's very easy for WEDSS to match Hep C cases against other conditions like syphilis or chlamydia or tuberculosis, what have you. So in this process, we're able to correct many race, ethnicity, or sex categories that might be indications in other disease incidents, but not so much in our specific DI. So you can see here this quarterly SAS code that's run, an example of a quarter that was completed more recently. We had 117 unknown race ethnicity cases when we ran the code. Once we provided that matching process to WEDSS, or once we provided that list to WEDSS to conduct that matching process, they corrected 45 of our 117 cases, and they gave us back 72 cases that were unknown, at which point we kind of conduct more of a manual process, and we look into and search across two databases. Our first database is CCAP, which is the Wisconsin Circuit Court Access. Our second primary external database that we'll search into is the Wisconsin Statewide Health Information Network, which we also call WISHIN. So in conducting more of these manual steps, we were able to correct 30 of these remaining 72 cases. So we had 42 unknown cases remaining out of the 117 initial cases. So that's a current step that we conduct quarterly to help improve more of the data collection and improvement process. So again, acknowledging data equity within the scope of this work means constantly reevaluating our workflows and how we're constructing our data to be meaningful and useful, and ultimately destigmatizing. That's the name of the game. So we're also always pivoting to what communities want to see or learn, how folks would prefer to be represented, and really constructing a system that allows for these pivots. So there's always room for improvement. So I wanted to take this time to also discuss some areas where we're looking to improve upon. So here are a list of goals that we're looking to start working on. And I just wanted to highlight some of these for what's in our future to improve case classification, data equity, and demographic data. The first of which is to host biannual meetings with the top 5 health systems in Wisconsin. This might be a little bit of a long shot, but it would be really essential to help build capacity among the provider network and also increase provider support for testing and treatment services. And then also expand treatment services, because that's really what we need right now, is that expansion of treatment services. Additionally, we would really like to improve our lab reporting on clinical information. And this kind of goes hand in hand with developing out our ECR. We are also looking to disaggregate racial and ethnic groups and improve the data surrounding Native populations, which we're currently in the process of getting involved with. We're working with GlideTech to kind of improve our demographic data among Native populations. So that's kind of an ongoing project for us. Getting a little bit more nitty gritty into this, so some goals in motion for us. We have a hepatitis C disease intervention specialist, Emily Hacker. Emily will be kind of responsible for improving data collection and data quality and improving gaps in information by conducting acute and perinatal case follow-up. Additionally, we're looking to improve automating race, ethnicity, and gender, and implementing ECR in 2023, which is going to be kind of that goal within our surveillance system itself. Additionally, we are looking to advance data collection practices among local health departments through trainings and improving our relationship with public health nurses. Ultimately, we're looking to improve risk information, improve demographic information, and collect more non-health related information, otherwise known as risk factors or exposures. And lastly, here on the slide, really looking to improve health and racial equity to drive positive reporting and dissemination practices. And this is kind of twofold here. We want to firstly improve data integration to elevate lived experiences and expose injustice. And secondly, use data visualizations to improve data equity and not further stereotype or stigmatize groups. I cannot say enough how important data equity is in this work, especially for folks who are, at the forefront of visualizing data. Really understanding what the community is thinking about the visualizations that you're putting out there is a really crucial way to further destigmatize these communities. And I wanted to just demonstrate a data equity example in regards to demographic data. So one way to do that is to separate out each racial category. So we're not necessarily trying to compare them to another. So while this can be difficult, it's a way to also mitigate any stigma or stereotypes that otherwise could be presented in data. So this is one way that we do it in our surveillance report. Again, this isn't the end all be all, but it's one way that we've learned to do it thus far. And you'll see here that the rates in Wisconsin are highest among Native people. So Indigenous communities in Wisconsin are definitely more affected by hepatitis C, and this is something we're also looking into so we can tease out some of the historical barriers at play in order to better support these communities. And this is also why our tribal coordinator meetings are so crucial to us. It's that major link that we have with frontline workers in these communities. All right, and this here is just a slide on our surveillance report. We have 2 documents that have been published on our program website. The first document is more comprehensive as an annual report. We also have a concise 2-pager document. We do our very best to modernize to inclusive and equitable language, and we're very intentional with terminology and really follow through with community feedback. And I just put a little quote that we have within our surveillance report that addresses communities that are impacted by different unequal access to healthcare, education, stigma, and the disproportionate access to various things that might lead people up to being exposed to hepatitis C. And with that, this is our last slide, where I just have some of our contact information located. And then I do have a little subset of post-presentation follow-up questions for folks, if we're able to put those on the screen.
Wow. Thank you, Kelsa and Kaylin, so much for that great presentation. I think maybe we can save the poll questions for our follow-up on February 22nd.
Yeah, we could absolutely do that. That's a great idea.
Great. I know we don't have much time, but I don't know, Kevin, if you wanted to say a few words, and then we can address some of the comments and the questions really quick.
Thanks, Zakia. So we have until 4, is that true?
Yes.
Yeah. So we have like 2 minutes, according to my clock. Kelsa,
I'm so sorry, y'all.
No, it was a fantastic presentation. Thank you, Kelsa and Kaylin. I really appreciated hearing all of the background and history and just the description of how your efforts have grown over the past 10 years. It's really amazing. And I was really struck by how the central role that partnerships play in the work that you do. I was just wondering, like, sort of like one question that I had, and it might be a good way to close out. From your end, what do you see as the most important things that you can do to make those partnerships work and to support them? Over.
Kaylin, I think I'll have you answer that question.
Sure. I would say by having a pretty open relationship with them, engaging them in different ways, going to where they're at, hosting meetings where they're at, going to meetings that already exist in their communities. I know with our elimination efforts now, we're trying to utilize Zoom to get a better statewide participation because our state's pretty large, so driving wise, it could take 5 to 6 hours to get somewhere up north. So just really engaging people on their level and where it makes sense to them, having our email addresses, phone numbers accessible. I also did a lot of pre-COVID, and now that things are coming back, I went to a lot of conferences and just being able to put our faces to our names and be more transparent and be more visible as state staff, which can be a little intimidating sometimes. And then showing up in places and just listening and taking the feedback and not really, I think sometimes people need to get comfortable. Like, you don't need a response always. Like, sometimes it's just taking the feedback that's given to you and then take it back to the government agency and discuss how best we can change something within the structure that exists. But just giving people spaces so they can be heard.
Awesome. Thank you so much. Well, it is 4 o'clock. That was a nice note to end on, by the way, Caitlin. Thank you for that.
Yes, thank you so much, Kaylin and Kelsa. And Kevin, sorry we kind of ran towards the end, but thank you all so much for sharing this information. It's very comprehensive, and I think it's something that everyone can learn from, regardless of their level of experience and their level of surveillance in their jurisdiction. So thank you all so much for attending today. We will have a follow-up session on February 22nd discussing these similar questions, and we will keep all of your questions and make sure that we get answers to them. So thank you all so much, and we will see you all on February 22nd.